So the next session is a panel discussion on the topic improving diet adherence in CKD, patient, dietitian, nephrologist perspective. So I would like to invite the panelists, Dr. Piyali Sarkar ma'am, Senior Consultant, Department of Nephrology, Manipal Hospital, Salt Lake, West Bengal. Then Dr. Sudeep Prakash sir, Senior Advisor and Associate Professor, Command Hospital, Lucknow. Then Dr. Rajesh Nair sir, Clinical Professor and HOD of Nephrology, Amrita Institute of Medical Sciences and Research Center at Kochi.
Good afternoon, everyone. The panel members has already been introduced. I would like to add Dr. Urmila Anand from Amrita Hospital, Faridabad was also supposed to join us. Unfortunately, she is unable to be here in person, but we have arranged for her to still be part of this process. So I'll be playing a couple of videos where she will be elaborating on some of the aspects. So the topic today is improving diet adherence in CKD, patient, dietitian, nephrologist perspective, and this will be not in a form of a lecture, but we will have a discussion, a conversational sort of interaction where we will be specifically addressing the adherence issue. Okay, most of the dietary principles in CKD dialysis is being deliberated in other sessions here. We will not be encroaching into that, but what is it are the issues when it comes to dietary adherence. We all know that in general, I'm sure at least in our part of the country, it is said that food is medicine. If you consider food as medicine, you will be healthy, right? And this cannot be more applicable. No, it cannot be truer other than in CKD. I would say it is most applicable in the context of CKD because we have studies showing that we have robust studies showing that modification of diet or what we call the medical nutrition therapy can modify the cause of chronic kidney disease and outcomes of dialysis, right. So this is relevant, but still we find that adherence is very poor among our population. And this is one situation where I have full sympathy for our patients for various reasons. We will be discussing this. This is one issue where I would say I will not find fault with the patients for not being adherent to the diet which we are prescribing or they are told about. So we'll have a question answer sort of sessions. We'll be discussing around 6 or 7 issues. I'll start with Dr. Piyali Sarkar. The adherence, we know that adherence is a problem. So my question to you, ma'am, is that how big a problem is it in your practice? Like how often do you find that people with we tell them to restrict everything, salt, water, phosphorus, potassium. So we find that most of the time they are not compliant with any of this. So how often do you find patients are compliant or non-compliant? And in your perception, which is the one nutrient where they have maximum difficulty in being adherent? What is your experience, ma'am?
Thank you, sir. At the outset, I would like to thank the organizers for selecting me to be one of the panelists in this esteemed conference. And so now going to the topic. I mean, so as we all know, as we all frequently encounter that the fluid restriction is the hardest part of it because it's a natural thing for the people to consume fluid, and especially in summertime, it's very difficult, for the patients to comply as well, and it's very difficult to, make them comply with the fluid restrictions that we impose. And so we try them in different ways, for non-diabetic patients or diabetic patients, we like those chewable lozenges, though they are hardly available, but some of the companies, they come up once in a while with those lozenges. And the second most important factor that, that I encounter is hyperkalemia. Hyperkalemia is quite prevalent, and more so because, it is derived from the plant and fruits. So the protein restriction people understand and they comply. But, restriction of taking some amounts of vegetables and fruits, it becomes too much for them. And even after restricting their diets so much, even then some amount of hyperkalemia is of course encountered in the day-to-day practice.
What about salt, ma'am? So one practical situation which we face in southern part of the country is some people are so adapted to salt. They associate when they are asked to not to take salt or reduce it, they complain that they are feeling weak. All those things which is not really objective. What do you tell your patients to enhance their compliance with low salt diet?
Yeah, so in my day-to-day practice, believe it or not, if I am consulting a patient for 10 minutes, I devote 4 minutes for diet consultation. And in this, I specifically tell them not to eat, not only to take too much of salt, but also salt containing food like pickles or muri, which is very prevalent in Bengal. And so, you have to use the carrot and stick method. So just telling them not to take salt, they won't comply, but you have to give them alternatives, what they can use for snacks. And
thank you. So one strategy which I sometimes try with salt especially is to tell them to stick to that low salt diet for a longer time, because I personally feel that salt is a habit which can be changed. Because most of the people cannot leave salt because they are used to it, but if they take low salt diet for an extended period of time, I think their adherence with low salt is better. So that is one strategy.
The sense of taste also alters, right?
Exactly, ma'am. Yeah. So thank you, ma'am. We will come back to you. There are more issues. There's no doubt that the diet advice we give people with kidney disease is complex. We want them to restrict multiple things, be it dialysis or CKD. They have to restrict sodium, potassium, salt, fluid. Okay, if it is one, suppose for example diabetes, you tell them to reduce calorie or sugar intake, but it's not like that in CKD. You want everything to be restricted, and it changes from time to time. For example, once they go on dialysis, you add fluid restriction. How do you prioritize, Dr. Sudeep, this is for you, how do you prioritize dietary goals to tackle, like in a newly diagnosed CKD patient? Should we shift from restricting everything or to a, which is now I think advocated, like you choose one and try to advise that, and then you how to go about it, how do you do it in your practice?
Thank you, sir. At the outset, I would like to thank the organizers for giving me the opportunity. Sir, I would like to start with the problem which I faced. Whenever the patients come, we are very close to the northern part of the country, and people, before coming to the nephrologist, they would have knocked all kinds of pathies, all doors, and different kind of advice like you will be put in a warm water bath and creatinine will come down. Then you put bricks on the lower foot end of your bed, and the kidneys will start working like a scooter starts working once you bend it on the sideways. All sorts of things will come to you. And in the middle or in the midst of the thing, if you give them a very complicated advice, they are not going to listen to you. So most of them are depressed. They have stopped spices, they have stopped all fat, they are eating boiled diet, they are not eating vegetables, they are not eating salads, chilke wali dal, all kind of nuts, all kind of kidney beans have been stopped. So what are they eating? They are eating just boiled vegetables and tasteless. Taste is the basic thing. If the person does not have taste in food, why will he eat food? So this is where we start, sir. So I feel that the simplicity is the key, sir. And we have to keep our advice simple, sir. Like first thing, what I try to tell them is try to find out what is their normal diet, because whatever I am advising them has to be very close to what they have been eating. So my first advice, if there is no complication, he is CKD 2, 3, then I tell them whatever is being cooked at your home, please eat that. And then another advice which we have to fight against is that reduce protein. They have been told by people that reduce protein in diet so that your kidney disease progression. It is true, but most of it, this advice is based on the Western protein diet, sir. Our diet, even if somebody is a very heavy.
The protein topic we will come to that a little later, Dr. Sudeep.
Sir, okay. Sir. So that's what I'm telling, that we don't need to reduce any kind of, whatever we are eating as such, it is deficient in diet. Similarly, they have been told not to eat fruits. So even if I tell somebody you eat whatever fruit you want to eat, so how much will he be able to eat? One orange, half an apple, that's it. He's going to eat in a day. So I would prefer to tell them that please eat food at less than 50 grams, that is one small ball. But what I tell them is don't drink juice. If you take juice, 1 glass of juice, if you take, you have effectively taken potassium around 4 or 5 oranges or apples. And juice you can drink 2-3 glasses. So I tell them don't take juice, and if you are taking nuts, then be restrictive. If you have crushed some kaju badam in kheer, there's no problem, but you don't take it in bulk. I think other than that, you don't need to. In fact, we should recommend fruits. It will improve the fiber. Fiber will improve the bowel movements. It will reduce hyperkalemia. Then salt content, the hypernatremia problems will get reduced. The acidosis problems will get reduced. So I would tell them that, sir. Then coming to the phosphates thing, sir. I don't think they need to reduce, as such they are taking very little amount of milk. So one line advice, if I would tell my patient, eat whatever is being cooked at your home, then don't repeat the same diet every day. If you do that, sir, then firstly it breaks the monotony. The spirits are high, he has got the mental ability to fight the disease. And secondly, it will take care of anything going into the body in excess. Like it will, one day he'll take one kind of fruit, other day he'll take another kind of fruit, then different kind of fibers, then different kind of salts, then different kind of micro nutrients. We have seen the speakers telling that CKD patient very easily get deficient in, especially those on dialysis, water soluble vitamins. So if you have a different diet plan every day in the week, I think it is going to take care of most of the things, sir. And secondly, we need to stick to the native dietary pattern and ask which part of the country the patient.
So you made some very valid points. One, we should not make any drastic changes in the diet plan.
Yes,
as far as possible, we should bring in modifications in the existing, what is the normal diet of the person.
Sir.
And there is a lot of misunderstanding even among medical community about restricting. You also often see people diagnosed with CKD with no edema whatsoever is told to restrict fluid. So that sort of unnecessary fluid restriction, unnecessary protein restriction is there. But I wanted to emphasize on one other aspect, which is instead of bombarding the patients with, suppose a patient is there, dialysis patient also, instead of trying to implement restrictions on say phosphorus, which some of them may need, potassium some of them will need, fluid most of them will require, salt almost all of them will require. Instead of trying to implement everything together, can we go ahead implementing one after another and choose one, let us get the hyperkalemia. So is that approach a good approach, and if you do that, how will you go about selecting the target? Which one to catch first?
Sir, I think this question was answered by Dr. Sinha very well in the talk. Initially, we tell them eat whatever you have been eating, a healthy diet pattern for everybody, non-CKD patient also. Then we see the patterns. Sodium is high, potassium is high, uric acid is high. Then we catch each and every problem in the diet, metabolic problem, that if you are having hyperkalemia, definitely for at least some time I'll tell them please don't take any fruits for a week or so, or if the sodium content is getting.
So the point you are making is from the adherence point of view, you agree that targeting one thing at a time is better than which is likely to be more acceptable.
It should not be a preventive restriction, sir. It should be a treating restriction. Once we find a problem, blood pressure not getting controlled.
Even when we have multiple issues to address, I think that is the general principle as of now. We should choose which is the most urgent one. It may be hyperkalemia, it may be volume overload, and try to tackle that first and then move on to the next target instead of implementing across the board restriction.
Yes.
Thank you for that. I think that is a very workable, and that is likely to improve the adherence of the patients as well. Then the next question is to Dr. Urmila. The question was about diet is, I am unable to see the folder. diet is part of our culture, right? So can you please, I am unable to see the video, the folder is not there. Can you please play that? All right, okay. The question is, no, more, I am unable to. Food is more than diet. I would say it is probably true for all. I'm unable to play it. I think I'm not used to this Apple ecosystem, so that is probably the issue. So can somebody play that from there? Yeah. So the question was, you can listen to her first.
Discussion. I apologize that I could not be here today with all of you because of some certain unexpected clinical commitments. I would like to thank Swalata and her team for this wonderful initiative, and I hope the conference all the very best. The question that you have put to me is that how dietary restrictions sort of impact our social and cultural life. In India, festivals, functions are all about food. You go to any kind of a marriage or any sort of Diwali, Holi celebrations, people will just look what is the food that we are going to get, and finally the review of the function depends on the food. And for a CKD patient, I realize is very challenging because in our food, the restrictions that our patients need to have is salt, and Indian food is just full of salt. Then it is about phosphorus. Most of the food stuff, protein, paneers and choles, bhatures and all that we eat is very high on protein, and also since the phosphorus content is very high. And finally, of course, fluids. The juices, the thandais, everything make things difficult for CKD patients. And this kind of restriction really impacts the social life. They get a little tense when they have to go for meetings, for this kind of gatherings. And also if there is an impromptu gathering, they are really concerned because they are not prepared for this. And being part of a group and to belong, it becomes difficult because their food will be a different kind of a food and they don't want to embarrass others. And sometimes it leads to social withdrawal also. But all is not lost. For our patients with CKD, they need to understand what is it that they can restrict. Food with salt and phosphorus don't make up the whole menu. So they can select food which are lesser on the salt and phosphorus and which will not create problems for them. And they need not eat everything that is on the spread, but they can eat small quantities of food which are allowed for them. Second, they can sort of take a meal before they go up to these bashes which last for hours so that they're not hungry, and they can forego most of the food which the others are taking. And thirdly, carry some renal healthy snacks with themselves so they can be at the meeting and the function and not leave it abruptly because of their dietary restrictions, and sort of munch something on the way during the function and eat whatever is allowed during the meal time. Like instead of having a lot of salt, they can have lemon juice and things like that. They can avoid the high-end chole chaats or papri chaats, but they can have a little bit of, the mattas and all those things. So, and your dietitian can guide you as to what they can eat. I do understand. And another point is, if you're a patient who has not only dietary issues, sometimes functions and all not only make them less compliant to their food, but it also to their medications that they need after their food. Thank you, Sreejith. Thank you very much.
Yeah, so I think it's of no doubt that most of our social life is centered around food. Festivals are events for feasting, not celebrations, and even I would say even individual family get-togethers happen over dinner. We go to functions, and if the guest is not eating, the host feels offended. So there is a compulsion to eat. But what Madam made the point is that there are some strategies to deal with all these things. Okay, so for this, the strategies may not come automatically to everyone. So it is possible that some of our patients can be given like some practical tips. She was telling that you eat before you go, and then to satisfy the host you have something, not everything, and you may be able to choose. So there are coping strategies with these things, even though it is not replacement for the normal life, but there are ways to deal with that also, and I think that is a very, very important component of giving dietary advice to our patients, because having family gatherings and festivals and is very frequent, right. So that can be a significant disruption to normal dietary practice for them. So moving on, next question is to you, Dr. Rajesh. We can tell a lot of things. We know a lot of things about renal diet now. Our knowledge about the what is good, what is effective has improved, and we do have dietitians. We have diet plans. We do tell our patients about their diet. But then, but we know that it's not getting done. So, what is your opinion? Is it primarily a failure of our knowledge and the information which we give to the patients, or is it behavioral and other barriers which is preventing patients from implementing or adhering to the required diet?
Thank you, Sreejith. That's a very nice question. I thank the organizers also for giving me the opportunity to be in this panel. Actually, the answer to that question is not very straightforward. It is actually a combination of both. See, I am coming from Kerala, so the literacy rates are very high. So I don't think that the knowledge is a major issue there, because most of the patients know what to be done, what is the best for them. Majority of them know. By the time they reach dialysis, they might have gone through so many interviews, so many discussions, so they know what is happening. Of course, it is a combination. Of course, some people may have some knowledge gaps, which mean it's for example, sometimes the phosphorus is more high in processed foods, so that additives are there which may be high in phosphorus. So these sort of small things, there may be some knowledge gaps, but by and large, people know what is renal diet. It is not very complicated once you tell the theory, but to apply it is very difficult. So what I see is that, say, I was speaking to a few patients in the last few weeks. I was asking them, do you know this? So they know, but the adherence is not great. It is very simple that the patients are very frustrated. Their family support may not be that great. The social environment actually warrants eat outs, and maybe they are very keen to get into festival sort of feasts. And most of them are actually depressed and probably exhausted too, because how long I should keep on doing this. So these are all basically behavioral issues which we need to address. So before telling the next point, let me ask you in this crowd, how many of you are having a dietitian along with you, counseling the patient with each CKD visit? Please raise your hands. See, there is only one hand. So probably we are at fault. Probably we have to have a dietitian along with us. Probably there are a lot of practice. I see around 50 to 60 patients a day. It's not possible for me to give a dietary advice to every patient. So there should be a support system where at least every third or fourth visit, there should be a interrogation as to, are you doing the same thing, what we have advised? So a dietary recall and find out what is happening. So unless we are doing that, because CKD, as we know, is a very slowly progressive disease. It is very difficult to make the patient, maybe to frighten the patient that something is going to happen. So a creatinine worsening probably is the only thing what we are going to see in the pre-dialysis phase. So probably we'll have to get the feedback from the patient, and we have to talk to them, and probably we have to listen to their diet. And as both the speakers told here, the diet has to be a tailored one. It is not one size fits all. So it has to be a tailored diet. Maybe we'll have to speak to the patient. Patient may be adherent to most of the things, and maybe few pitfalls here and there we can correct. But the most important is keep on speaking to them, interrogating. Maybe a dietitian's advice every third or fourth visit, so that the patient knows that his diet is very important. There is something called a motivational interviewing, a positive reinforcement, which can be done so that this can. So I do agree that knowledge gaps are there, but behavioral issues is more than that.
Yeah, so I think you made a very valid point. Most of the things we as nephrologists, as dietitians, as well as the patients know. There may be a proportion of people who don't know. Patients may not be knowing. Most of us will know what is to be done, what about protein. But there is a difference between knowing and doing. So, especially what personally I feel is that when it comes to CKD diet, the patients need assistance with doing. They can be given the information, but to practically implement it, there are a lot of barriers which is probably beyond their control also. So, the doing part requires assistance, like that is why we discuss various strategies, like for example, instead of implementing multiple interventions at the same time, asking them to restrict across the board everything, to choose one. So, a stepwise strategy, and then instead of giving them an artificial diet which our dietitians routinely do, they have a printout which they give a copy. Instead of giving a totally new diet, try to make changes in their existing diet which will meet the dietary goals. And Dr. Archana showed pictures showing and hands on, showing them pictures, you had nice slides. So, that also makes a great difference is what I feel. So, there are many things, even though we can be happy that I gave counseling, I told the patient, I gave them a handout, that may not be enough, that is knowing part. But unfortunately for kidney disease patients, implementation also requires a lot of hand holding where we can make a difference. I would say especially the dietitians can make a difference. Thank you sir for that point. Then moving on, Dr. Piali, we know that individualized, see the CKD patients also is not all the same, right. Some are diabetic, some are non-diabetic, some of them are obese, some of them are malnourished, some of them require fluid restriction, some of them don't. But if we send to a dietitian, at least in our institution what routinely used to happen, they have a printed renal diet. Okay, and they give renal diet to everybody, be it nephrotic, be it CKD stage 3, CKD stage 5, dialysis, transplant, it is renal diet. We have banned that practice after nephrology department started. But then individualization is I think beyond question, that is very, very relevant. So, one-to-one, face-to-face counseling makes a difference. But then how do you go about doing it? Do you try to do that in your practice? How do you adapt advice to individual patients? How do you basically customize the basic question is, when we know all those things, it is not a blanket prescription. So, how to go about customizing diet prescription to patients based on their biological situations or their cultural as well as family, and how do you do it in your practice?
Yeah, I mean, so I am what I do is not very common. Actually, it's not very feasible, maybe. I mostly practice in private and also in the government institutions sometimes, but mostly in the private. And I devote a lot of time to my patients, and I do amongst in my 10 minutes of consultation, I devote at least 4 minutes to explaining the nutrition, okay, to them. And based on the reports that they have individually, some patients may be having hyperkalemia, some patients may be having hyperphosphatemia, some patients however may be having fluid overload and their electrolytes are okay. So depending on that, it's important to individually look at each patient's problem individually, and then decide the diet plan for those patients. And having said that also, I mean, so I cannot ignore that a diet chart is not important, because a diet chart is important because it gives them basic guideline as to what they should eat and what they should not eat at all, okay. The vegetables and the fruits that they can consume and they cannot consume. So that is very important. And at the same time, I think regular consultation by dietitians, who visit them in the dialysis units as well as in the IPD setups and also in the OPDs. So that is one way to go about it. And also giving them more information. Nowadays, the patients are quite smart enough, so they have smartphones. So, I mean, they can to some extent, those who are educated and young patients who are electronically savvy, then they can take the help of the social media to adjust their diet according to the requirements and their specific needs.
Thank you, ma'am. So, I think it is very evident that we need to look at multiple aspects. Their own food habits, a diet which is common in the north may not be relevant in the south, something which is relevant in Andhra will not be applicable in Kerala. We need to look at that. Some families have their own cooking practices. Of course, in addition to the medical parameters, we need to look at multiple other aspects when we individualize diet prescription. Moving on, there are now lots of digital help for diet. All these health app, including our mobile phones, have applications where you can chart your diet. Most of the Indian things are also there. So, how have you been using these sort of things in your clinical practice? If so, what have you tried and how successful or how useful it has been, and what do you think, will it be can be used as a mainstream thing in a context of the Indian context where a good number of people may not have still smartphones? What do you take on this, Dr. Sreejith?
Sir, thank you for the question. Sir, I did try one or two of these apps. Initial ones had most of the diets which were mainly non-vegetarian and Western diets, but the Indian ones have come. But the biggest thing which I felt was firstly my group of patients, and I am sure many other doctors also would be having the group of patients who belong to slightly lower socioeconomic strata, sir. So even if they have a smartphone, all of them do have smartphone, but capturing the technology use, they are not very comfortable at it. In fact, aged people 65, 67, they are educated also, but they are not very willing to switch on to an app. They would rather be happy to come and take advice from a dietitian or a doctor. And they find it very complicated, like clicking what you have eaten, it will tell you how much potassium or phosphorus you have taken. So then we devised a method of using a WhatsApp channel, sir. I have made a WhatsApp channel, sir. I have taken the QR scanner code printout. It's kept on my table and my colleague's table, sir, and also on the reception. We tell the patient to screen it. So they become members. And so this hassle of adding to the group and all is out, sir. Then initially I used to make videos or pamphlets or these flyers. Then we switched over to podcast, small 2 minutes, 3 minutes radio advices, podcasts, not very long, sir. They found this thing the most useful, sir. They said while working we listen to it whenever we find that there's a podcast. Reading a flyer or reading an advice or seeing a video, they say that hum dekh nahi paaye, we did not get time. But podcast and all, and not very long, sir, 3 minutes, 4 minutes. So I personally found this thing the most useful part, sir. But yes, with the OPD load increasing and our involvement getting in intervention and all those things, I think we must take a use of these technologies. And I personally felt this WhatsApp channel is a very simple thing to do and easily doable, sir. If a better app comes, why not? Definitely, yes.
So absolutely. So I think very valid point. In fact, you made a very relevant point about voice messages.
Yes,
it may not be necessarily podcast,
small, short, sir, 2 minutes,
short
3
messages.
minutes.
In fact, I am aware of studies which have shown that when you look at patient compliance and adherence to the instructions, somebody has done studies showing that voice messages are the most effective one, rather than text messages they tend to ignore, they don't follow, but voice messages are much more impactful. So WhatsApp in that way is, I think, a very powerful platform. Personally, I would say tracking from the patient point of view, I should be honest, I have tried to track my own diet, but I have miserably failed. Okay, because it has to be done consistently, and maybe I am not that disciplined to do that. I think that is one problem probably we may face when we ask patients to track their diet. But now there are ways to capture photos using the app, and the app will analyze and give you the dietary content. But I think he made a very valid point that digital tools are available, it is easy to use, and there are things which are already shown to make an impact when it comes to delivering these sort of messages. Absolutely. Thank you, Dr. Sreejith, for that very important message. Moving on to Dr. Rajesh, we had a debate today morning on plant-based diet. Okay, so but I think the general awareness, maybe among nephrologists, that awareness has improved, and most of us are now aware that plant-based diet is probably better. But I think there are still concerns about whether it will produce hyperkalemia, how safe it is, how good it is. So what is your policy like? Do you aggressively promote plant-based or plant-predominant diet to your patients? At what stage do you prioritize protein preservation over protein restriction? And what is your concern about hyperkalemia and all? How do you go about implementing plant-based diet in the face of these concerns?
Yeah, at the outset, let me say that I never push any patient for a predominant plant-based diet. And by and large, as I think Dr. Satish has discussed in detail, there is the what exact definition of plant-based diet is not very clear. Because suppose we are taking eggs, so is it plant-based plus eggs? If you take fish, then so it's basically all the dietary plants are all mixed diets. It is maybe predominantly plant-based, we can say. So in my practice, I never push the patient to go for plant-based. But by and large, what we can say is that the protein restriction of close to 0.8 gram per kg per day for maybe a 60 kg man will come to around 50 to 55 grams of protein. So in the non-dialysis, I'm talking about non-dialysis patients. Those patients, 50 gram protein, even if the patient is taking 2 or 3 egg whites per day with some dal or maybe some nuts and all, probably may not reach that 50 grams. So protein restriction in the initial phase of maybe CKD stage 3 and maybe up to 4 may not be that much needed actually. Patient can have his routine diet with may not go with an additional proteins. That's what I would do usually. And as we all know, once we see a patient in the OPD, we will start off, what are your symptoms? Are you doing well? What are the medications you are on? You look at the labs, look at the medications, titrate the blood pressure medications. And then by the time we are about to finish the consultation, suddenly, sir, watch, is there anything I need to do with the diet? So the time is over. We are also, yeah, you do something, go. So that's usually what happens, I'm very honestly. So the time we spend for dietary counseling is actually very less. I am also part of that practice. So I think we should spend more time to do that. And this, I do agree that the KDIGO 2024 guidelines say that plant-based dietary modules will be helpful in retarding the progression of CKD. The concern of hyperkalemia occurs only when the patient goes into stage 3 or 4 or maybe 4 or 5, when the patient reaches close to end stage. A patient who is prone to hyperkalemia will know beforehand, because patient may be on ACE-ARB, patient may be having a type 4 RTA, so patient may be having a borderline hyperkalemia already. So such patients we need to probably look at very carefully. So a diabetic patient who is has a metabolic syndrome, who is obese, probably a plant-based diet helps, especially in the early stages of CKD. Whereas when the CKD progresses towards end stage, the issue of hyperkalemia, vitamin deficiency, all will come in the picture. So in that case, probably we'll have to be more careful about it. That's the general thing I can say.
Yeah, thank you. So the key message I think from what you are saying is that one, our diet is low protein, so we need not restrict protein. We should not be restricting protein. I strongly believe in that. We have also done studies in living donors, nephrotic, CKDs, dialysis patients, and it is always less than 0.7, 0.6. We have as low as 0.4. So protein restriction we don't impose at all. I think that's general consensus. And I strongly feel when we say plant-based, to me, what I interpret it is you have to include plants and fruits. It is not pure vegetarian diet. I would always at any stage, even for healthy, for myself also, I would advise you always include plants and fruits in your diet, and I would give the same advice to CKD patients also. I will not ask them to become vegetarian or take non-vegetarian, but I would go by a mixed diet, but I will advise them to include as much as possible vegetables and fruits in their diet, which is likely to be helpful. And we will respond only if there is hyperkalemia. We will not anticipate hyperkalemia and modify diet. That's again what I think you were telling. We have run out of time. I wanted to make one more point which I think we don't have time to discuss. One serious problem I am sure all of us are facing is when you give a diet chart to the patient, you give dietary advice, you spend a lot of time. The dietitian gives advice, the patient will go home, the neighbor, the friend, the uncle, the auntie will come, they will watch YouTube videos and they go on a totally different diet. Okay. So we don't have time to debate that, but I think this is a very, very serious issue, which I think something needs to be done about it from an association like this. The solution to that is to put out lot of evidence-based things. It can be videos, it can be educational things, it can be conversational podcasts. But I think for customized for the Indian context, we need to come out with push it on social media platforms individually as well as collectively, so that also now the evidence based diet is lacking out of the discussion, out of the conversation. Conversation is all about all sort of other diets, which I think is very harmful to the patient. So, because we have run out of time, we will wrap up making few points. One is that adherence is poor, but looks like we know a lot of things what is to be done. The main challenge seems to be in implementing or getting the patients to implement it, the doing part. And as of now, I think we also know, especially the dietitians will be able to help with that. There are many strategies we know which will help in patients in improving their adherence. I think it is important for us to look at those options, and we will of course need much more renal dietitians. We are short of those things. Of course, we will need more studies looking at Indian diets and the plant predominant diet. We need more scientific information, but even with available information, I think we can work on the implementation part by bringing out protocols, strategies, which I think in a systematic way, and educating our patients. With that, I would like to thank all the 4 panel members, including Dr. Urmila, for your time and your valuable and your informed thoughts from your experience on these important topics. Thank you very much.
Thank you, sir.
Thank you. Thank you.
Thank you, sir.